Well, it's my privilege to invite our panelists here, Dr. Alex Shoustari, Dr. Janice Mehnert, and Dr. Michael Davies here up to the stage. We really didn't have an order for this on the agenda, I don't think, but maybe we'll go. Alex, how do you feel about going, since I see you here top to bottom, starting with you and giving us an update on rare melanomas?
Yeah, whatever order you guys want to do.
Sounds good.
I'm happy to chat.
Everybody created a few kind of level setting slides, and then we'll jump into some questions after. So go for it, Alex.
Hi, everybody. I think Dr. Patel did such a good job actually being a rare melanoma expert that I will not actually be doing a lot of sort of data review. And you guys, in person, the people tuning in online are, you guys are the most educated, the most proactive, you're, the most interested, smartest people about this. And as are we among the oncology community. I want to sort of be kind of like provocative on purpose. So I'm going to be a little bit provocative about, what our challenges are. Much of this is not directed to the people in the room. It's the rest of the community out there and sort of, setting up how I think we might be able to do a little bit better. So they told me how to work this, and I thought I did. Okay, so here's some of the disclosures. We talk about a lot of drugs that all of us have really worked with a lot of these companies, so I think it's fair to say. So for example, Iovance Biotherapeutics and folks like that. I think that the rare melanoma community is always up against this sort of why should we invest time and money into something that's not that common. And I'm sort of calling it the clinical trial corporate culture. And it's not, again, it's not the folks that have, largely it's not the folks that sponsor this kind of forum, right? That, they're putting their money where their mouth is. But it's, there are a lot of other companies that I'm sure my colleagues can attest, sort of having discussions saying this stuff looks interesting, but, and then hitting a brick wall eventually and being told, well, yeah, we talked it over with, we're going in a different direction. We don't have a lot of mouse models and sort of robust things that skin melanomas have had and have had for decades. So sometimes you can't always prove that something will work ahead of time until you happen to give it to a person who's desperate for a new treatment, and then it happens to work. And I'll give you an example of that. And then there's this kind of, I think third, almost like mixed blessing, which is we have more options now than we ever did, which is great. But 10 years ago, it was a lot easier to convince somebody and an oncologist, near Houston or near New York to sort of say, well, I'm going to recommend they come in and brave the traffic and think about a clinical trial with you, because 10 years ago, it was like, well, we didn't have much for these rare melanomas. Now we do have some options, and I think we have to stay kind of vigilant with our messaging and why it's still important for us to, get the message out that there are things out there that are worth traveling for, that are worth participating in trials to learn from. So I'll walk through just a couple of these as an example. So I kind of attested to this. Dr. Patel did a great job laying out how we're always kind of first in class in melanoma the last 10 or 15 years, and we're all very proud of that. The message has gotten out to companies and the venture capital, that funds small biotech companies, that melanoma is a good proving ground. But really, they're starting to get picky. And the phase 1 trials are starting to say, yeah, that's really great. We want to do cutaneous melanoma. And we have these meetings with them and say, really, in a safety study, aren't you curious? Do you never know? And they're like, well, yeah, we kind of want cutaneous melanoma, because they need fast results and they need early shrinkage to then take it up the chain and say, hey, VC and biotech and everybody else, why don't you put another $20 million into our coffers to run a bigger trial? You know, and that's just the reality of how it works, and that's a challenge for us. It's difficult, for example, the lack of models, it's difficult to grow mucosal melanomas, you know, the ones that are on hairless surfaces as cell lines. There are colleagues of ours and folks here that work with this. That always slows us down because the models that we do have are a little more finicky, they're hard to generalize, and they're hard to sort of say, well, I have a patient-derived xenograft, I'm gonna ship it now to Dr. Patel's group or to Dr. Mehnert's group and have them work with it. They're sort of not able to be worked like that. So how do we make progress with this results now culture and sort of without these mouse models? And unfortunately, we have to be resourceful and say, well, let's get them into phase 1 trials and listen to what the best model of what melanoma will do in humans is, unfortunately, testing it in human beings. And you can't just do that willy-nilly. You have to have a lot of, thoughtful insights. But I think we have that. And I think the bigger problem is convincing companies not to be too picky. And so the lifileucel example is a great one. So was this designed to be a mucosal melanoma drug? It was not. But they were smart enough, and I would say humble enough, not to limit and say, well, we only want cutaneous melanoma. What's the best proven drug been so far? Tebentafusp. And that trial, I will tell you, because I was involved in the first in human trial, that was a complete accident. They didn't even realize that uveal melanoma would be the best signal for them. But again, they weren't sort of presupposing what they were looking for. And then, it's now led to a drug that actually works. I'll skip for the sake of time. It's great to have things like Nivo-Ipi, Nivo-Rela, standard PD-1 monotherapy as options, but it's not great for the rare melanomas in the long run if fewer people are referred for clinical trials. Now, I get trials are not for everybody, but we have to keep that pipeline open. So Dr. Patel, went through this targeted therapy option, right? It does look good, but right now it's a pivotal test for us in uveal melanoma. It's only in the first line setting. And I already have lost count of the number of people that have gotten immunotherapy with their local doctors and then come and said, do you have a good option for me? And at the moment, and for the next year or two, I don't have a good way to give them this drug. And so I think there needs to be continued sort of messaging out there that we need to, keep that pipeline open. And you guys are the biggest part of this. I mean, it really is the awareness on Facebook. It's the patient forums and it's events like these that do that. So thank you very much.
Thanks, Alex. Sorry for not giving you a better introduction there. I was obviously nervous and forgot to say who you are. Dr. Shoustari is a medical oncologist at Memorial Sloan Kettering, where he sees melanoma, but also is a leader in the rare melanoma space. So next, why don't we go down the agenda? It goes to Dr. Mehnert, who's at the Perlmutter Cancer Center. Dr. Mehnert is also a medical oncologist and co-chair of the ECOG Akron Melanoma Committee. Dr. Mehnert will talk to us essentially about what we do after the frontline.
Thank you. Waiting for my slides to come up. So my assigned portion of this session was to just spend a few seconds talking about treatment-resistant melanoma. And so I'm sort of just going to glaze through a couple of places where we need to, I think carefully when we have some of the great options that we've been talking about are not helpful. When they fail patients, what do we do next and where do we go from there? So I'll just start with just a couple of thoughts on what do we mean by resistant. I think we all can agree at this point in time that immunotherapy is an important backbone therapy in the first line for patients with advanced disease. And the results of our DREAMseq study, which was an absolutely heroic endeavor that took years to finally have data that prove where we should start first BRAF-directed therapy versus immunotherapy. It's finally read out, and I think that while many of us, felt like we knew the answer, seeing the gold star durable responses we were getting from immunotherapy in our patients in the clinic, it was very important to prove this. So we know where to start now in patients that have stage 4 disease. But immunotherapy fails patients with both primary resistance. We've all had patients who, we're treating and they just progress right through the immunotherapy we've offered, and secondary resistance, where patients may have a nice response and then all of a sudden, they're off therapy for a while and disease comes back. So, I think where we start to talk about resistance, and I'm focusing on stage 4 for the this very brief discussion in these slides, because to me that's where we start talking about resistant. I think it's important for us to start as a community thinking about what do we do, what's our preferred second line option, and is it trial? Because we have, as Dr. Shoustari just said, many options, but if options aren't robust, then sometimes it's smarter, as a clinician and as a patient, to sort of save some of our readily approved approaches for later, when we have less control over the options that can be presented versus when we're screening patients for a clinical trial. And that brings me to my next bullet point on this slide. Do we, immediately manipulate a different checkpoint target, or do we think about still doing clinical research in that space? What do I mean by that? Well, I think there's not necessarily nationally consensus on our ideal first-line regimen. And again, some of that is because we have patients who have different needs in front of us in the office. But we do have 3 approved options. We have still single-agent anti-PD-1 in the form of nivolumab. I should have pembrolizumab on that slide as well. We have combination, ipilimumab and nivolumab, and we have combination nivolumab and relatlimab. All of these have slightly different toxicity profiles, inhibiting slightly different targets. And so understanding what we immediately do next is, I think, a bit of an open question. So for instance, if for whatever reason you're a patient that had received nivolumab or pembrolizumab alone, do we simply add ipilimumab or relatlimab, or switch to nivolumab or relatlimab at that point? If you had combination therapy, do we just switch to the other combination? I think it's an open question, and we don't necessarily have clear research that's set up in this second line to prove these points. And finally, I think we have to remember that immunotherapy fails patients when toxicity becomes an issue. I think that we have come miles from where we started in terms of how to effectively manage immunotherapy toxicity, but nonetheless, there's always a patient where we start with a few doses and we're just unable to successfully and safely continue down that road to treat that patient. And so I think in all of these scenarios, despite the fact that we have these absolutely amazing advances in the front line, we need to really think about what to do next and continue as a field to come up with options. What are we talking about in terms of trials? I do think in many places in the second line space, we're back to phase 1, as Dr. Shoustari was recommending, even for cutaneous melanoma. And I think, at least in my mind at the moment, there's not a clear option that's jumping immediately out at me as the absolute best thing for patients. Usually when patients come to see me in consultation, we review their standard of care options. We review the clinical trial options we have available at NYU. And actually, I am always try to be as comprehensive as possible, anything, in a tri-state area or even further, if there's, exciting developments, because I do believe that part of the reason we've come so far as a community is because we were very generous with referring patients when exciting options were available, even if it wasn't at our home institution. I think that we do have a couple interesting molecules out there. There's 2 trials that we're part of, SGM-BB228, which is an investigational co-stimulatory antibody bispecific directed against CD228 and 4-1BB. It's a very interesting combination that I think will begin to open up and accrue more broadly over these next few months. There's a neat molecule we're working with from a company called GV20, which is an IgG1 monoclonal antibody that's directed against human IGSF8, which is an mRNA. It has overexpression in many cancer types, including melanoma, and actually it inhibits a checkpoint that prevents effective NK killing of tumor cells, so that way by blocking it, you're enhancing innate immunity. So I think that phase 1 trials with immunotherapy plus X are certainly a reasonable consideration if immunotherapy fails a patient up front. Let's switch and talk about targeted therapies a little bit. So we do have very, very effective second-line therapy for patients who have whose tumors have mutations in BRAF V600E or K. Less so in patients whose tumors have mutations in other targets. But this is sort of a, again, an overview of how far we've come in terms of the fact that we even have an understanding of how complex this biology can be. I think that in general, because we've not always seen, and I say the word always because it's not never seen the same kind of durability with targeted therapies we do with immunotherapy, we tend to think of targeted therapy as more of our salvage option. Although I think we all in our clinics have a collection of patients who, for whatever reason, did get that long-term durable remission with targeted therapy and didn't break through with resistance, which is always lovely to see. So I think we've got a smattering of different, trials out there that we've heard about as a community, either preliminary reports or will soon read out. I think NRAS still remains a very elusive target. Although we have more candidates than we've had previously in that space, exorafenib, which is the molecule by Kinnate, belvarafenib through Roche, and naporafenib through Arsaka, which is now, previously was Novartis' compound, is now going to a randomized phase 3. And then we still have our, investigation or initiated trials that are trying to manipulate this target as well. I think that in line with rare melanomas, we shouldn't forget about NF1, tumors that have NF1 loss. Historically, that should be even up to 25% of tumors. It's actually been far less in my own clinic for whatever reason. But there's interesting data that, for instance, inhibitors of SHP2 could be very useful in patients whose tumor has this mutation profile. I put the RevMed compound in the miscellaneous, even though it's technically a pan-RAF inhibitor, because I think it's just a little bit different mechanism of action as the other NRAS inhibitors. Certainly, it's getting a lot of excitement in the lung cancer space and pancreas cancer space, so for patients who have a G12C mutation. So I think it's an important space to watch for NRAS mutant tumors in melanoma, and we're accruing that trial at NYU as well. And then finally, either figuring out how to make BRAF therapy more effective up front, or figuring out its appropriate place. These are all trials that have already closed or read out, two of which I was intimately involved with. So we had a phase 1-2 trial of dabrafenib, trametinib, and hydroxychloroquine being an inhibitor of autophagy that would block the autophagy pathway, which can nourish tumors and allow them to hunker down into this little spore-like state and survive. And that had a nice signal in an IIT, but we did ultimately move it to a phase 3, which unfortunately closed down between COVID and some pharmaceutical decision-making that had forced us to close the study earlier. So we don't really have a great frontline BRAF trial for patients where immunotherapy has failed at the moment. We've presented dabrafenib trametinib versus dabrafenib trametinib and navitoclax, which is BH3, a BH3 BCL2 mimetic, which again, fell short of where we wanted it to be in terms of a signal, but we're still analyzing that data. And then finally, we recently had results of the Succumbit trial, which again sort of proved our point that immunotherapy first is best, but how do we learn and use about how do we figure out and further define the role of BRAF-directed therapy? So I think we have still a lot of interest in this space, but a lot of work to be done. I'm going to spend very little time on these last few slides because Dr. Patel just did such a great job discussing TIL therapy and adaptive T-cell therapy. But I think the biggest question for all of us is where is this going to fit and where are we going to use it? And certainly we're all waiting with bated breath to see programs get up, running, and rolling so we can offer this to patients that, for whom, again, our first-line therapies have not been effective. But I think that ultimately what we need to remember about this process is it's something that is not as simple as perhaps prescribing some of the other therapies we have due to its complex tissue processing, the time required to grow up the T cells after that tissue is processed, the need for hospitalization, and the severity of side effects, even though when properly managed, patients, can actually do quite well. And the nice thing about it is it's sort of for an intense period of time, and then there's sort of a respite after that. So I think that this is going to be something we're spending a lot of time talking about. Figuring out where it fits for an individual patient is going to be a very detailed, intricate conversation. It's going to be a highly selected therapy. But yeah, I think just such an important advance and something we're just so glad to really have seen come to life in these last few weeks. Again, these are sort of things we've already seen today, so I'm going to glaze over them in the interest of time.
Thank you, Dr. Mehnert. And finally, Dr. Michael Davies, it's my pleasure and privilege to introduce, is Professor and Chair and Medical Oncologist of the Melanoma Medical Oncology Department at MD Anderson. And he'll give us some updates here where we're thinking about going with CNS disease.
Great, thank you so much. And thank you so much to the MRA for inviting me to participate today. My grandfather died of melanoma, so it's melanoma on the face. Didn't spread through the blood to the brain, but invaded directly back to it. And so melanoma has always been a very personal issue for my family. And as I've taken care of patients with melanoma over the years, the idea of central nervous system metastasis has been one of the things that not only patients fear, but their physicians fear as well. And it's an important problem, and we've been able to demonstrate in melanoma that we can take this problem on head on. But I think it also is an important theme to talk about in a session that really says no patients left behind, because as we've talked about clinical trials, this is an area where we still need to do better in making clinical trials available. So why do we talk about CNS metastasis in melanoma? So historically, melanoma has a higher risk of spreading to the brain and the leptomeninges than any other cancer. In early series, when they did autopsy studies on patients who had died from melanoma, over 80% of patients had evidence that the cancer cells had made it to the brain. And while often that's a late event in most cancers, when we see patients with newly diagnosed stage 4 melanoma, 20% of them have CNS involvement at the diagnosis of stage 4. Now, one of the reasons we've always had fear is because this is the worst site in terms of what patients' life expectancy is. And so for decades, studies done by our group, by other groups, showed that when patients were diagnosed with melanoma that spread to the brain, that the average survival was only 4 months. And one of the take-home messages today is that has changed, and there is absolutely reason for hope, not just for extending life, but for actually curing patients. And so that's going to be one of the take-home messages. But I will say one of our challenges is that historically, over 98% of clinical trials have excluded patients who have evidence of CNS involvement. And so one of the reasons we as clinicians fear CNS metastases is not just because of prognosis, but because it means it closes the door to so many treatment options. And this is something that we need to advocate for as a community, not just the patients, but physicians as well. And I will say that's not a problem that's unique to melanoma. But just as an example, when Dr. Patel showed you the list of all of those treatments that have been approved for melanoma over the last decade, not a single patient with active CNS disease was included in any of the trials that led to FDA approval. So this is still a barrier that we have to overcome. Now again, that's the significance of the problem, but where is the progress? So again, on the left, the very first paper I published when I was a junior faculty member at MD Anderson showed when we looked back at patients who've been diagnosed with brain metastasis from melanoma, the overall survival was about 4 months, and the chance of being alive 3 years after initial diagnosis was about 5%. On the right, we've now updated that data looking at our current era. After the approval of anti-PD-1, after the approval of BRAF and MEK inhibitors, showing we've basically tripled the average survival. So from when patients are diagnosed with a brain metastasis, on average they're surviving about 15 months. And perhaps most importantly, we have a tail on the curve. About 30% of patients appear to be long-term survivors. So this is not necessarily a death sentence anymore. And so patients do not need to give up hope if they get an MRI that shows brain metastasis. Now, I think, again, from the systemic therapy standpoint, the thing that's really changed the game has been immunotherapy. We've done immunotherapy trials after drugs got approved, where we then asked, are these safe and effective in patients with brain metastases? And 2 different clinical trials showed that in patients who have asymptomatic brain metastases, so that means the brain metastasis was found because the patient had an MRI done as part of their restaging, not because they were having symptoms, but we picked up small asymptomatic brain metastases, that in those patients, if we treat with Ipi and Nivo, the long-term response rate is 50 to 60%, basically as good as in patients who don't have evidence of CNS involvement. And notably, that is actually the scenario where the Ipi-Nivo combination is much better than single-agent PD-1. This is probably our most automatic indication for who should get Ipi-Nivo combination therapy. Now, what the trials did show, and particularly the Checkmate 204 study by Dr. Tabi, was that if we treated patients who had symptoms from their brain metastases, including patients who needed any dose of steroids, that response rates drops from 50 to 60% down to 20%. And so one of the messages I have for anybody who's a patient with metastatic melanoma watching this is that one of the things we need to do is actually get MRIs of the brain as part of your routine restaging. And certainly what we need to do ultimately is try to figure out who are the patients who really need this the most, and that's a very active area of research. But what I would also say from this is, again, even our trials for patients with brain metastases almost all excluded patients with symptomatic disease. And as a field, that is now one of our great challenges. How do we improve outcomes in that population of patients? So targeted therapy, focusing on the patients with BRAF mutations, which is about 50% of patients with metastatic melanoma. We have 3 FDA-approved BRAF and MEK inhibitors. And what we see with all of them is that they actually have a very high chance of getting brain metastases to shrink, even in patients with symptoms, even with patients on steroids. And that actually we have a better chance of getting the disease under control initially with targeted therapy than we do with immunotherapy. However, in this scenario, those responses last for a very short time. And now it's not only shorter than what we see with immunotherapy, but it's shorter than how targeted therapy works in the rest of the body. So on average, although we can get the tumors under control for at least a while in 80% of patients with these combination targeted therapies, on average that lasts 6 months. That's about half as long as what we see at other sites of the body. And indeed, in our clinical trials, 50% of the patients had tumors that started to grow in the brain while the rest of their body was controlled, starting to suggest that, again, there can be a difference between brain metastases and tumors in other places. And so in the targeted therapy area, our real challenges is how do we make those responses more durable? And although this is a problem at every site, it is a truly critical problem in the brain. Now, in some ways, the final frontier, and Dr. Patel alluded to this, is leptomeningeal disease. As much as I've talked to you about the fact that patients with brain metastases, we've made tremendous progress in improving their overall survival over the last 15 years, we basically haven't seen that with leptomeningeal disease, which is when the cancer is on the lining of the brain, either in the skull or down the spinal cord. And those patients continue to have very poor outcomes. And those patients were excluded even from our trials for patients with brain metastases. And so this has actually been one of the huge challenges, is just getting a trial open that patients with LMD can participate in. And Dr. Patel talked to you about this trial we did at MD Anderson, which showed some evidence that even when patients had progressed on anti-PD-1 given intravenously, that putting the medicine into the spinal fluid could be effective. In some ways, the bigger message is that we proved it was feasible to have a clinical trial for patients with leptomeningeal disease. And this is, again, one of the things of once we, again, announced we had this trial, the patients came. We know that this is needed. We know that this is one of the things that can be done. And that's one of those important barriers to breakthrough is fears about having these types of clinical trials. So in summary, much progress has been made. Overall survival is dramatically improving. We've shown that it's feasible to have clinical trials in patients where melanoma has spread to the brain and even the leptomeningeal disease. And actually at this meeting, there's even growing research efforts. But it does remain an area with many areas of challenge, including patients with symptomatic tumors, with leptomeningeal disease, the continued exclusion of most patients from clinical trials, and don't have time to go into it, but a lot of really interesting data that really suggests that brain metastases can act very differently than tumors anywhere else in the body. And just as kind of a take home, we've talked a lot about data, But this is a patient of mine, a 38-year-old man who presented with widely metastatic disease and had 2 small spots in the brain. He got treated with immunotherapy, with targeted therapy, with radiation, with surgery. And what his PET scan shows 2 years later is he had no melanoma from the neck down. But he had too many brain metastases to count, and that's what he died from. And so this is an area that is a really specific area of need. I'm really proud to be part of the melanoma community that's taken on this challenge, but it remains one of the areas that we need to continue to work on. Thank you.
Thank you, Dr. Davis. All right, if there's questions from the audience, we've got the microphones. I think just raise your hand, the microphone can circulate. I see we've got one here, so we can start there. Oh, we've got several. I can just put my questions away, I guess. we've got.
Is it on? Okay. So, no mouse models for the rare cancers, but there are a lot of dogs that get mucosal melanoma. So, what is the possibility of working with your vet schools to actually do something synergistic in that domain? Because it does seem mouse models may be out, but maybe we can learn something there instead.
Yeah, definitely. You guys can hear me, right? Yeah, so in that short overview, I certainly didn't cover that, but certainly there are DVMs, vet, lab-based veterinarians who've shown, that the area and the types of the area of the body and the types of molecular alterations they get are shared. So absolutely, there are some, I think, inchoate, very early sort of efforts to collaborate. I will say that if mouse experiments are expensive, sort of dog experiments are obviously a little bit more expensive than that, but certainly much, much better than anything else we have. Absolutely.
And it's also a difficulty, I think, in the mice, we induce the melanoma. Maybe we feel one way about that. I don't know how many of us would want to actually induce a melanoma in a dog just so we could study it. So you're kind of left to the incidences that they have,
I think it's just more frequent in dogs than it is in people.
Sure, and mice.
Ready clinical population.
Yeah.
Right. I think I wouldn't want you to induce dogs.
I don't know if you know, but in, I think it's Scotland or the UK, they actually have done till for dogs. And we saw some evidence of that December before last. They had about 5 or 6 different species of dogs, 5 or 6 different dogs, and they gave them their own till back, and it can be effective in that population as well. So.
I had a question. With metastatic mucosal melanoma, typically, how long does the patient stay on immunotherapy? I know some folks in our group stay on a year if it hasn't really metastasized. If it has metastasized, they'll stay on 2 years or even longer. And then is the duration like 2 years from the point you start the therapy or 2 years from when you're NED?
Yeah, so a lot baked into that question, and I think you already know what I'm going to answer because we haven't fully figured out how to stop treatment successfully in skin melanomas, and so we struggle certainly with the less common ones. We know kind of 3 successful ways to stop in skin melanomas, and there's a prospective trial that it's Dr. Gibney's trial, right?
Yeah, PET-STOP.
Yeah, the PET-STOP study, which is one of my favorite acronyms. I'm not as good at acronyms as Dr. Patel is, thinking of great acronyms on the fly, but they had a 1 year, if your PET scan is negative at 1 year, can you stop? And I think those results will be really important because we all have our gut feelings that, mucosal is more aggressive or is trickier, in some ways. But until we kind of get that baseline, I don't have one single answer for you. So the 3 ways, and I feel like I'm monopolizing the discussion here, but the 3 ways would be, if you have significant side effects, you certainly aren't going to, get more doses just to get more doses, and you can still be cured. There is that kind of idea that if you have a complete response, there's quite a few people who can be cured. And then, that 2-year mark that's now so common, it's actually semi-arbitrary, but now we have enough data from skin melanoma-dominated studies that, you can be cured at that time point. But which of those for an individual patient, certainly outside the scope of this panel, I want to know what my colleagues
So
think.
just so Alex doesn't feel alone, so I think the other end of the question is when do you start immunotherapy in a patient with mucosal melanoma? So when Dr. Patel talked about the trial in cutaneous melanoma patients where the cancer had spread to the lymph nodes, the idea of starting immunotherapy before you did surgery instead of doing it just afterwards was based in part on laboratory experiments that really suggested immunotherapy works better if you start it when the tumor's in place than doing it after the tumor has been removed. And again, the SWOG 1801 study really proved that. And that's what we really all had hoped to see. That being said, in cutaneous melanoma to this point, we've been doing that only in patients who've developed metastases. Mucosal melanoma is a disease where we actually often think about it when patients present only with a primary tumor. These tumors can be in very bad places. The surgery and local treatments can actually be very morbid. And so both because we want to try and make surgery less morbid, and again, if immunotherapy works better if you start it with tumor in place, I think neoadjuvant therapy is also something we're exploring more and more. So instead of waiting until it's metastasized or waiting until after you've done surgery, actually doing it up front. So it's not just the when you stop, it's actually the when you start, I think is the other interesting question.
Great. Let's start. Let's just make our way through the room here. Yeah, sure.
Hi. So I think Michael spoke a little bit about this. My question revolves around encouraging the patients who are here today and also the survivors' families. So I'm a stage 4 patient's wife. I'm almost 30 years old. I'm 29. And my goal in coming here today was to be encouraged. So that's why my question revolves around that. I heard a lot about overall survival, and the longest I heard was 7 years. I'll be 36 in 7 years. So should we be encouraged overall survival will improve beyond 7 years as time goes on, and if so, specifically why?
Yeah, so, it's one of the things, when we went through our training, melanoma was one of these cancers that was on the short list of cancers where we didn't have any effective treatments. At the same time, Dr. Patel mentioned in 1998, high-dose interleukin-2 got approved for patients with metastatic melanoma. And it's not because it worked in so many patients, but the patients that it worked in were actually still alive 30 years later. It actually set the track record that when you get an effective immune response against cancer, that this can actually last for a long time. When you hear us talking about 7 years, that's predominantly because these treatments are so new. That's how much follow-up we have. One of the things, again, and I sort of alluded to this, is that for many different clinical trials, many different types of cancer, we look at these survival curves and say, okay, this is how patients did. And with this trial, we were able to shift it over a little bit, which meant you were extending life, but you weren't curing. And where we really shifted to in melanoma is this idea of looking out and seeing, is there a point where if a patient is alive and well after the start of their treatment, is that somebody who actually probably isn't going to die from melanoma? And what we've seen for most of our immunotherapies is in the clinical trials is that point seems to be about 3 years from when you start, that we start to see the survival curve flatten out. Now, can we tell you that that means that that patient is going to be alive 30 years from now? Time will tell. But there is a precedent for that with the interleukin-2. And that's actually, again, as we talk about what medians are in this and that, or 1 and 2 years, ultimately, our goal is long-term survivor, and melanoma is a disease that often affects patients who are young and healthy, as your husband is. And that's why this has always been a disease where it's not just been about pushing the line, but actually getting the long-term survival.
I think you described it great, Mike. You called it a tail on that curve, which is really, it flattens, and each time point after that, it seems to be quite stable. So that tail is really impressive, that only time will tell if that's really durable. And you asked a fascinating question at MD Anderson a few years ago, and I think you might be reviving it, which is, what does a metastatic melanoma patient die from? It may sound like it's science of the obvious. It's a little bit like saying, what does a patient with kidney failure die from? But they may not die from their kidney failure if they have adequate dialysis and so forth. And so maybe you can tell us a little bit about that question and how you're answering it.
Well, and I will say that I participated in a symposium a few years ago with a patient who, again, was battling stage 4 disease, had received treatment, had done really well. And she said one time, she asked her doctor, what does it mean to be cured of melanoma? And he said, it means you died of something else. It's a little bit dark.
Yeah.
It was a surgeon, but it was true. We sort of talk with our patients like we still haven't had anybody with melanoma live forever. There's always something out there. But this idea, so one of the things again that when I talk about the importance of brain metastasis, historically when we looked at what melanoma patients who've died from melanoma died from, the most common thing was uncontrolled brain metastases. And so it's not just, again, saying that problems are significant because of how prevalent they are, but it's also because what impact they have. And brain metastasis, again, is for me, one of the reasons it's so important. It's not just survival, but the patient I showed you, the last 6 months of his life, he wasn't himself. His father talks about that. He was gone for 6 months because of how the brain metastases affected his personality. And so there's all sorts of important endpoints. But just to come back to your question, our goal for patients and our hope for patients is to cure. The reason we say 7 years is just because that's what we have data for. But it doesn't mean that we think that that's about to fall off the precipice. It's actually one of the questions, and you said how long to continue with immunotherapy. The other question we're getting now more and more is how often do I need to get scans? And we hope to be able to come back one day and be able to say, no, you don't need scans anymore. I think realistically, whether it's for treatments, whether it's for surgery, whether it's for scans, hopefully one day we can come up with a test that tells you, do you need this or not? Really to personalize really all the different sort of stages that we have in the care of our patients.
I'll just add one thing to the discussion, which is that you may find when you're seeing physicians that, if you say, am I cured, there may be some dancing around that. I know I feel that way because, when I started my career, there was chemotherapy and nothing else, and chemotherapy was not effective. So I still feel sometimes, even when I'm pretty sure somebody's cured, I hold my breath still, and it's hard for me as a physician to use that word. But I think you should be encouraged by the fact that we do continue to have, long-term survivors that, can be here to help us refine our field and, help us learn more about the future. But I think that if you find that, there's a reason behind it.
Yeah, good point. Over here. Other questions? Yeah.
Well, yeah, one more here. Doctor, you answered. I had 2 questions, and you answered the one about the frequency of scans. So I won't ask that one. The second question I have, though, is, I was diagnosed 5 years ago with stage 4 metastatic. And at the time, I remember in my own readings and research that the effectiveness of immunotherapy was limited to about 30% of patients. The rest it didn't seem to have much effect on. In my readings, I also saw that there was some correlation, very strong correlation between certain lifestyle changes and the effectiveness of immunodrugs, one being diet. Apparently the consumption of large quantities of insoluble plant fiber seemed to increase the effectiveness of these immunodrugs. Has there been any other research in regards to not only diet but lifestyle changes that might contribute to the increased effectiveness of some of these immunodrugs?
Yeah.
Great question. Yeah, go ahead, Mike.
Yeah, so just to say, it's an interesting example of when people have made observations, and then the question is can we figure out, well, 1, is it real, and then 2, what causes it? Because if we could figure out what causes it, then maybe we can figure out how to broaden that out. So in the early days, everything sort of focused on, well, what mutations are there? And then we moved to, is PD-L1 expressed or not, or how many mutations? What's become very clear that you're kind of alluding to is there's many lifestyle and host factors that are probably very important determinants, not only of how effective our treatments are, but also how safe that they are. The associations with diet are quite interesting in that there's a lot of lines of evidence right now that suggests that the microbiome we have in our body is very important for how effective or how well our immune system works, how safe it is. And so To that point, we know that the foods that you eat affect the bacteria that you have in your intestines. To the point where we are doing prospective clinical trials where we're giving patients the standard medicines, what we're randomizing them to are different diets to see if there are specific diets that people should eat that really will impact the microbiome in a favorable way, and whether that will actually improve the effectiveness of immune therapy. What I will say is that we all hope one day we have, like, if we could ever find this is the one bacteria you have, then we make a probiotic with that. We're not there yet. But to your point, actually, the data that we have from multiple studies looking at patients treated with immunotherapy, they showed that a diverse microbiome seemed to correlate the best with improved outcomes. The best way to have that is by eating a high fiber diet. And so, you know, for our patients who ask, what can I do, you know, to help make this work better? We talk about healthy lifestyle. We talk about that. I don't know if anybody wants to talk about Allison's work in exercise or any of the other sort of lifestyle interventions.
Yeah, so one of my former colleagues now at Stanford, Dr. Betoff-Warner, has done a whole lot of studies where you put mice on a little mouse treadmill, essentially. And there's almost no form of cancer or disease where putting a little mouse on a little mouse treadmill and doing, a moderate amount of mouse exercise won't help. It really is true. So, what I recommend, but also what I'd love to hear the patient side of it in a broader, forum like this, is it's difficult to have that conversation in my clinic room because we don't yet have those big studies. But also, the answer almost sounds too obvious that when I give them the answer of what the cutting edge sort of science says, they kind of go, yeah, you're kind of just giving me the answer my cardiologist gives me. And I'm like, no, this is the immunotherapy answer. It's aerobic exercise and it's a high fiber diet. And then everyone kind of goes, well, but have you heard of turmeric or have you heard of this? And you're like, yes, I've heard of turmeric. Yes, I've heard of, this person who claims that their diet's the only diet.
Alex, I wonder though, when you have that dialogue, what do you say to the marathon runner who shows up in your clinic with melanoma? Because they're saying, I'm already doing this aerobic exercise.
I say,
why?
What'd you do? What'd you do wrong? No, okay. No, I mean, that proves it, right? It's not always rational.
So just to say where we often, again, learn more from making the wrong guess than the right guess. So Jen McQuaid, when she was a fellow, worked with me. We actually were looking at patients who've been treated with targeted therapy and then with immunotherapy. Jennifer had done a lot of work on different types of medicine and really came with this hypothesis. In many diseases, obesity is associated with worse outcomes with treatment. And Jennifer went and looked, and we had the very surprising observation that with both targeted therapy and with immunotherapy, obesity correlated with better outcomes. And over the years, trying to understand what's really driven that, there's a lot of data now that may be driven by essentially hormone production by fat. Testosterone promotes resistance. But just to say, because we had patients who were coming in who were essentially starving themselves.
Yeah.
And just to say, this is an area we recognize we don't have all the answers yet, but we certainly don't have evidence that starving oneself makes your treatments work better. And just to say, and Sapna knows this, when we did the analysis, so with almost all of our treatments, women do better than men. And actually among women, the BMI didn't make a huge difference. What we saw was that fat men had outcomes like women. It's sort of, we proposed the donut trial, so being in Texas. But it's
good acronym, right?
It's one of those areas, as you say, these observations lead us to research to try to understand what's the underlying mechanism so that we can really, understand what drives those types of changes and associations to hopefully be able to give people evidence-based recommendations. And we're still in our infancy, This is a treatment where, again, you would say before 2011, we had never had a trial that improved overall survival. The standard of care in 2011 was clinical trial. And as you've heard today, you could argue the standard of care is still to go on a clinical trial. But we have a lot to learn still. But those are good questions to ask.
We're down to our last few minutes, so I think we've got time for one more. I'm going to make Cody
Yeah,
decide.
so we have an online question, and the question is, what is being done to address the side effects of drugs, and particularly the way that they impact organs in the body?
So I can
Yeah.
speak a little bit to that. We at NYU, a lot of the focus of our melanoma spore is dedicated toward trying to understand toxicity and towards whether we can develop biomarkers that can help us predict who will get toxicity. That's the holy grail. I think we're still a far way away from that, but it is a very interesting area of research. My partner, Jeff Weber, is PI on a study, which is our frontline trial at NYU right now, which is looking at ipilimumab, nivolumab, and relatlimab combined with sarilumab to inhibit IL-6, which his work has shown is important. Modifying that cytokine is important in moderating toxicity. So I think there is active research out there. The other thing that I'm really excited about that we're working on is understanding differences in toxicity among different populations. So patients who are either from racially or ethnically diverse or medically underserved populations may experience toxicities at a different rate, whether it's due to biology, whether it's due, there's social factors or social determinants of health that are part of that. So we have a large collaboration, actually Dr. Shoustari is going to help us with that, as our colleagues at MD Anderson, to try to understand that a little bit better. So there's a lot going on in that space.
Yeah, we now have these units at a lot of institutions called IO tox units, or derm tox, or GI tox units. So looking at the toxicity associated with immunotherapy, but we also know targeted therapy can give patients these toxicities. So it's really important for us, if you have a toxicity, to be able to report it. And many places are even piloting more patient-reported outcome tools. So you can sit at home and on your device say, I've got this side effect. It'll come into your clinic team, and then they can determine, is this one that we need to act on tonight, tomorrow? Or is it just good information, FYI, that we're logging? So I think, reporting is important. Make sure you speak up if you have your side effects. And then, making sure that we're managing them effectively. There was a fascinating symposium at the Society of Immunotherapy for Cancer this year, where a breast cancer patient wrote her team a very strongly worded letter saying, you chose this therapy for me. You said I needed to do neoadjuvant, then I needed to do adjuvant, even though my tumor had completely died away with the neoadjuvant therapy. You made me do it for 6 to 9 months. It was time off work. It was really impactful for my family, and quality of life fell off a cliff. And now I'm left with all these side effects. And is anybody listening? You kept recommending these treatments, and nobody was listening to me. So I think that's a fascinating, from a medical standpoint, we have evidence to say you need this amount of therapy, but that's where it ends for us. We need patients to tell us, where does it impact them, and where does the rubber meet the road, so we can actually start thinking about shortening our durations or adjusting the treatments to manage these side effects. So.
Just to add on to the clinical trial theme specifically, so again, just to clarify, so what Janice is talking about, there are now clinical trials where we're adding medicines to our standard therapy to ask if that will reduce the side effects. And we finally have gotten to the point now, we have so many medicines to manage many of these side effects, there are clinical trials to say what's the best way to manage the side effects. And so those are, again, as we talk about clinical trials, not only about can we make our treatments more effective, but can we make them safer as well.
Well, I would like to thank our panelists here. Thank you guys so much for joining us up here. Thanks to the online audience, and we'll move on to the next session. Thanks, guys.